Hello everyone, and welcome to our third session of a Population Data Science webinar series. It's my pleasure to welcome Heather Gidding and Hannah Moore. Their presentation will be on the use of probabilistic linkage of national immunization and state-based health records to evaluate Australia's immunization program. By way of introduction, Dr. Heather Gidding is an infectious diseases epidemiologist with a broad interest in conducting high-quality quantitative epidemiological studies to inform public health practice, especially around infectious disease burden and control by vaccination in vulnerable populations and Aboriginal children. She is passionate about maximizing the use of routinely collected data for epidemiological research, in particular using data linkage methods. She is currently conducting research using linked health and vaccine coverage data for 2 Australian states to look at who was more likely to have delayed vaccine uptake and why, as well as measure the real-world vaccine effectiveness in different population groups. Dr. Hannah Moore is a program head, infectious and vaccines, and head of infectious disease and epidemiological team with the Wesfarmers Centre of Vaccines and Infectious Diseases at the Telethon Kids Institute in Perth, Australia. Her passion for research involves large population-based data sets to investigate how to prevent and reduce serious respiratory and other infectious diseases in children. Dr. Moore has developed expertise in the epidemiology of pediatric infectious diseases, focusing on respiratory infections using data linkage methodologies. She established the first ever linkages with routine microbiology data to population-based administrative health datasets in Western Australia. And using these data, which includes the only population-based RSV dataset in Australia, Dr. Moore pioneered the first dynamic transmission model for RSV using these unique data. She is developing knowledge of how best to identify pathogen-specific burden of disease using administrative data, and she has contributed to maternal influenza vaccination policy through showing that antenatal influenza vaccine does not result in adverse birth outcomes and is currently contributing to national seasonal influenza vaccination policy through her involvement in a collaborative network across Australia. Dr. Moore is the Western Australia lead on the first national study investigating real-world vaccine effectiveness of routine immunizations in birth cohorts for Western Australia and New South Wales. You'll notice on the bio there's also a Twitter handle for Dr. Moore at Hannah Moore WA, if you'd like to use that as well. I'd also like to remind you that through the GoToWebinar control panel, there is a chat function which you'll be able to use to ask questions or make comments during the presentation. I'll be monitoring the chat function and can present them to you orally so everyone can hear as well as respond to the chat questions. So please feel free to do that as well. So without further ado, I'd like to hand it over to Heather.
Right. Thank you very much, Anne, for that lovely introduction, and hello everybody. And thank you also to Population Data BC and the International Population Data Linkage Network for the opportunity to present our research today. I'll start the ball rolling and then I'll hand over to Hannah, so we'll do a little bit of a tag team for the talk. Okay. So Hannah and I have been working together over the last 6 years. It's been a labour of love pulling all of these data together, hasn't it, Hannah?
Certainly has.
Yeah, and we've had a great group of researchers, investigators working with us both in New South Wales and Western Australia that are on this slide, and particularly we've had some terrific input from the government representatives in Western Australia and New South Wales as well to ensure that our research has policy relevance for the health departments. So just a little bit of an outline of our talk. I'll start off with a little bit on why linkage would be important with the immunisation register, and Hannah will talk a little bit about the specific aims of our project and the processes for how we went about linking the data together, how we assembled our cohort and what the limitations with our current linkage system are. And then we'll talk a little bit about some of the outcomes that we've got out of our data linkage program to date and what some of the policy implications are for those outcomes. And I'll finish off with what we hope would be some proposed future linkages to overcome some of the limitations with the current linkage system, and conclude on that note. So I'll start off with a little bit on the background about why you want to link up your immunisation register. So firstly, Australia is one of only a handful of countries that have a national population register, a whole of population-based register. It started off as a childhood immunisation register in 1996, and now it's a whole of life register. And in terms of the childhood registry, the registration is based on every child who's registered in Medicare, which is Australia's universal health system, and by 1 year of age, this is virtually 99% complete enumeration of all children. So it's a terrific population-based register and one of only a handful in the world. So why would we, now that we've got this valuable immunisation register, and why would other countries, including Australia, need to link that register up to other data sets, particularly when the immunisation register itself has been such a valuable asset in providing coverage and information about how timely the vaccines have been. And the reason for that is that our immunisation register only has limited information about each of the children, such as age and sex and postcode of residence. And so it's really not sufficient in its own right to identify particular subpopulations who may be at increased risk or in whom the vaccine might not work as well, and also control for important clinical and demographic confounders that might impact on the vaccine effects. And importantly, the unlinked immunisation data can't provide population-based estimates of the rate of disease by vaccination status, and this is needed to really accurately calculate vaccine effectiveness. So I'll hand over to Hannah, who'll take you through the next set of slides and the project aims.
Thanks, Heather. So the main aim of our project was really to, first of all, just establish the process of linking multiple state and Commonwealth data sets, and I'll explain that a little bit more in the next slide. But this represents the first time that such state and Commonwealth linkages have really occurred. So we focus this on Western Australia and New South Wales, which are on opposite sides of the country. But together, these two states represent about 40% of Australia's total birth cohort. And the reason for those two states will become apparent in the next slide. But the main two aims that we had with this overall program of work, the first one was around coverage, so assessing vaccination coverage and vaccination effectiveness at a population level, but also in different at-risk populations. And also adjoined to that was looking at factors that are associated with delayed vaccination, and then looking at what impact that would have in terms of vaccine effectiveness. So this is, so there you go, there's a picture of Australia for those who can't quite picture what it all looks like with the different states. So just to talk a little bit about data linkage in Australia, the first state that really had established data linkage was in Western Australia. So data linkage has been around in Western Australia since the 1970s, and it was really formalised with the Western Australian data linkage system in 1995. From there, for the rest of Australia, the next well-established data linkage unit was in New South Wales through the Centre of Health Record Linkage, which was established in 2006. Since that time, we've actually got data linkage units across most states and territories across Australia. However, these two states really represent the states that have been progressing with data linkage work the most. We also have the AIHW, which is the Australian Institute of Health and Welfare. They were established in 2012, and they look at all the Commonwealth data. And the reason why this is important, as for those that are not familiar, Australia is a federated country, so we have states and then we have an overall Commonwealth. And some of the administrative data sets that we are interested in, some are governed by the states and some are governed by the Commonwealth. So you've got a list on the slide there of the types of data that are available just through state linkages. But the main one to note is that immunisation data is under the federal or the Commonwealth data. So if you want to look at immunisation data in conjunction with other states, you need to use cross-jurisdictional data linkage. So this was an opportunity for us to look at a state linkage in WA to a state linkage in New South Wales to a Commonwealth linkage for immunisations. So I'll now just go through the process of doing this cross-jurisdictional linkage, and there's a reference to a paper there in the Australian New Zealand Journal of Public Health that details all of these processes. So it was a bit of a long process to go through, and I will show you a bit of a time scale of how we went through all of this and the time that it took. But there's 3 key steps that were involved with this. First of all was state linkages within Western Australia and within New South Wales. So our linkage is based on the birth register and perinatal data sets, which is called the Midwives Notification System in Western Australia and the perinatal data collection in New South Wales. And from here we established a population-based birth cohort between 1996 and 2012. And these data sets together had maternal and infant demographic information, pregnancy information and birth information. Then with each of the states, we had linked outcome data, as you can see on the slide here, and this is all our morbidity data. So includes information such as hospitalisations, emergency department, which is outpatient episodes, notifications of vaccine preventable and non-vaccine preventable diseases, and the added bonus in WA is that we have PathWest laboratory data. And you can see as a note on the slide here that the birth register is the one that was really used for linkage, and over 95% of births in Australia are registered. So how we did this is that within each state linkage unit, there was a state linkage key which linked the individual data sets within that state. So in Western Australia, that was done through the Western Australian data linkage system. In New South Wales, that was done through the Centre for Health Record Linkage, or the Cheryl system, and they provided these state linkage keys. Second major step was national data integration. So from the Commonwealth, the main data set we were interested in here was the Australian Childhood Immunisation Register, which contained all our vaccination data for children that were in the birth cohort. What had to happen is that there was a secure transfer of details from each of the states to the AIHW to allow linkage, and there was a process in getting memorandum of understanding from each of those states to transfer that data across from state to state to a Commonwealth department. The second step was then transferring details from the Australian Childhood Immunisation Register to the linkage unit at AIHW. And then that involved getting a public interest certificate, which is basically a data custodian sign-off for the immunisation data. And this was the first time that this had actually occurred. And then the third step in this was then linkage of the cohort and providing a national linkage key that was specific for this project. The third data was that, so we had 3 different linkage units involved here, from the blue circles on the left, AIHW, the WA and the Cheryl system. They then all provided with their linkage keys, and the WA and New South Wales, the Cheryl, involved their morbidity data and their birth cohort data, and AIHW had the vaccination data. All of those important data sets were then transferred into a secure access remote laboratory when we use a system called the SURE system, which is by the Sachs Institute based in Sydney. It's a very secure remote access laboratory. So all the information was put into there. The public interest certificate was involved in allowing that data to be transferred. Then there were several quality assurance checks that AIHW wanted to do. That was part of the agreement. And then after that was done, there was access for the research investigators such as myself and Heather to be able to access the data in that secure remote laboratory. So this basically shows all of that in a complicated slide, and this is what is in our paper. So it is quite a long, drawn-out process. It did take us a while, but it was really quite key to establish the transfer of all this information across different jurisdictions. So there's really, 3 key linkage units. There was about 8 or 9 ethics units that were involved in accessing these data. So it was a big project. So this just a simple timeline just shows how long it did take. So as I mentioned, there's lots of different ethics applications and data linkage applications that we needed to go through. I think we started this process in about 2012, and this just shows a bit of a timeline of how long it took to get some of these things occurring. So we received our data in late 2015, so it was about 3 years in the making to get all of these data, which was frustrating at times. But I think, yeah, this really represented the first time that Australia has really integrated these big data sets across borders. And I think importantly now we've established a process. So in the next time when we do these linkages, it should be a lot quicker. So what I'll do now is I'll hand back to Heather to talk a little bit more about the assembling of the actual study cohort.
Thanks, Hannah. Yes, after we had gone through the process of linking all of the data, we then had to go about assembling our retrospective cohort. So this was obviously children, as Hannah mentioned, born between 1996 and 2012. We had all their health data and vaccination records up to 2013. So the first step obviously was to establish our cohort of children, and I'll talk a little bit more about the details of this on the next slide. And then we had to add in the details of their a unique set of vaccination records for each child, and we had to do this obviously in dose and date order of being vaccinated, and also then add in all of what we would consider to be our outcome data, particularly whether they got a vaccine preventable disease or not, and also their emergency department and hospital admission data. And these data provided information not only about the severe outcomes of the vaccine preventable diseases, but also additional information about comorbidities as well. So the person time may end when they got a vaccine preventable disease or when they died, and then we divided that person time up by the number of vaccines that they'd received. So the next slide just shows you how it's quite a detailed slide again, but the key thing is that we had to, of course, start off when we assembled our cohort with a unique record for each child. And so this meant removing duplicates of the same child and then also only including children that had both a perinatal record and a birth record, a birth registration record. And the reason for this is that obviously the perinatal data in both states is a very rich source of information about the child, and we only wanted to include children in our study that were able to provide us with all of that rich information. But unfortunately, the perinatal data in each state often doesn't contain the baby's name. So in order for us to do any linkages, and as Hannah mentioned, send the identifiers down to AIHW for linkage to the immunisation register, we really did need the child's name. So we were able to get that from the birth registration. And so we only included children from New South Wales and WA in our cohort that had both a perinatal record and a birth registration. But this was about 97.5% of all children who had a perinatal record that we were able to include. And then after we'd done that, of course, we only wanted live births, so then we removed children who were stillborn or whose I guess some of the other data sets also identified if a child had died soon after birth, so they couldn't contribute any person time to our analyses, so we excluded those children as well. So we ended up with over 1.9 million children in our final birth cohort born between 1996 and 2012. The other thing that we were able to do is, because we had multiple data sets, is enhance the Indigenous status of our children. And this was quite important because Indigenous children do have a higher rate of vaccine preventable diseases, and in addition we really don't know how effective the vaccine is in Indigenous children. So we did want to, as best as possible, identify these children and investigate whether the vaccines were working and compare the burden of disease. And so we were able, because we had multiple data sets, we were able to combine these together to enhance the Indigenous status. And we used 4 methods. One was whether on any record they were identified as Indigenous, whether on all their records they were identified as Indigenous. And then we had an algorithm, which is the reference for that is below by Christensen. And Christensen's method was based on the National Best Practice Guidelines for data linkage activities relating to Aboriginal and Torres Strait Islander people. And Christensen's algorithm was an application of these guidelines. And I won't go into the details, but we looked at it including all data sets except for the death data. And then we also did the algorithm excluding the immunisation registry. And this was because we wanted to see how the immunisation register compared with an enhanced estimate of Indigenous status on all the other databases combined. So as mentioned, we had over 1.9 million children with 18 million person years of follow-up. In the paper that's published in the International Journal Population Data Science, we report the comparisons with some of the unlinked data that we were able to compare with, vaccination coverage, disease rates and death rates, and there was very good agreement. So we felt that we were able to show that the quality of the linkage was very good. And we also found that our cohort was similar to all live-born children in the perinatal data collection. However, there were some differences in that obviously we were only able to include children who had both a registered birth registration as well as being on the perinatal data. And so some of the children who had a perinatal record but didn't have a birth registration, they were actually quite different, even though they were a very small proportion. So registered children included fewer Indigenous children and young mothers, and mothers who smoked during pregnancy, and mothers who lived in remote regions or with a low socio-economic index for areas score. And so when we're using these data, we really need to keep that in mind, that our results are absolutely generalisable to children who've got a birth registration, but they may not be representative of children who don't have a birth registration. The other limitation is that we based our cohort on children who were born in New South Wales or Western Australia. So obviously we can't look at children who were born overseas. And also we can't identify when a child moved interstate or overseas. And so there might be some unobserved outcomes and loss to follow-up. But that proportion is quite small, particularly if you're only following up the child for the first couple of years of their life. So I'll hand you back now to Hannah, who will talk about some examples of outcomes to date.
Okay, thanks, Heather. So as I mentioned at the beginning, one of our main aims was looking at vaccination coverage. And through doing this, through linking all of these information together, I guess the value added that we could do with all these linked data sets is that we could identify different groups in the population and look at coverage within those specific groups. So obviously looking at Aboriginal children and non-Aboriginal children with our validated algorithm was a key group of interest. But there was also other risk groups that we wanted to look at, and you can see some that are listed on the slide there. So the main aim of this was to compare those that were unvaccinated compared to those that were vaccinated, but also looking at those that are vaccinated, looking at vaccination on time and also delayed vaccination, which I will go through in a little bit. So as I said, that's sort of a repeat there. So looking at the added value of looking at linkage, so you could look at some of the evaluation of coverage for these targeted programs. So one example here is through looking at the pneumococcal conjugate vaccine, PCV, in extremely preterm children. So this table here just shows what the vaccination schedule is for pneumococcal disease in Australia. So we had the 7-valent PCV vaccine introduced in 2001 for Aboriginal children, a 2, 4, 6 month dosing schedule with a booster at 12 to 18 months of the 23-valent polysaccharide vaccine. At the same time, there was also a targeted program for high-risk children. And this group of high-risk children also included preterm births. So these are extremely preterm births defined as under 28 weeks gestation. And they were recommended to have the 7-valent PCV at 2, 4 and 6 months, as well as a 12-month booster. And then in 2005, that's the beginning of the universal program for all children for a 3-month, for 2, 4 and 6 month dosing schedule. And then in 2011, we changed to the 13-valent program, which was the same as for the high risk children. So you can see the different changes that have happened there. But what we really wanted to evaluate here was those ones in bold, those extremely preterm children. So this graph here shows the quite poor coverage in this at-risk group. So if you see the purple line, if you just look at that, that is the 3rd dose of the PCV at 12 months in those preterm children. So you can see in the earlier years of this slide here, this is when the targeted program for those at-risk children was around, but the coverage was actually quite poor, and coverage only really picked up when the universal program began. So the dotted line up the top there is for all children for that 3rd dose. So it's only really when the universal program began did the coverage for this targeted group reach a good limit, same as for all children. You can see in the green line, in that sort of greeny teal line, in this mustard line, these are the boosters that were given specifically for this high risk group, and you can see the coverage there is actually quite low. I think I've got some aggregate numbers there. So for that 12-month dose in particular, which is the dose that's only given for this targeted group, the coverage was really low. And this was the first time we were able to evaluate how well the coverage was in this particular risk group, and it's really not that great. But Heather will show you some slide a little bit later on about what we think about this. So just to touch on a little bit of the standard reporting for coverage. So as I'm sure most of you in the immunisation world might be aware, we generally use this 3rd dose coverage as a measure of how well a vaccination coverage is in a population. And one of the reasons for that, it's based on WHO standard reporting for coverage. And this is how you can look at how a program is performing in different regions and then across different global regions across the world. So Australia is part of the Western Pacific region. And when you look at DTP3 coverage, it is quite high. And we often say in Australia that our DTP3 coverage is above 90%. However, what we're really interested in here is looking at on-time vaccination. So vaccines for DTP and also for PCV are given at 2, 4 and 6 months of age. So we're really interested to say, well, how many of these kids are actually getting these vaccines on time? So we define on time as being 2 weeks prior to a recommended age up to 30 days post the recommended age. And this 3rd dose assumption, which is used in global reporting and quite often different markers of how well coverage is basically this 3rd dose that's given any time before 12 months. So you can see there's quite a big difference there between on-time coverage and this 3rd dose assumption. So these purple bars just show the different windows of on-time coverage that we were interested in looking at in this study. And there's actually a thought, and this has been around for a while now in Australia, that we do have very high rates of vaccine-preventable diseases, especially in Aboriginal children. And there has been a thought, is this really failure of the vaccine or is this failure to vaccinate? So looking at this on-time vaccination coverage is really important, especially for Aboriginal children. So that was one of the part questions for this analysis. And this paper has recently been published in the June edition of Vaccines. You can see the reference there. So we just were looking at DTP vaccines in this particular area. So this is a bit of a repeat of the slide that Heather showed you. So we had 1.9 million children in the cohort. We started off with 26.5 million immunisation records. which took us a while to clean and go through, and we removed the duplicates and removed those records that didn't match the cohort and those that had some sort of strange data on them. But realistically, all of the ones that we did remove because of that was less than 1% of the whole cohort. So we ended up with the final cohort all with their DTP vaccination information for 1.9 million children. And we looked at uptake of the 2, 4 and 6 month dose by 13 different population subgroups, and you can see them listed there on the slide. In interest of time, though, I won't go through all of them. Obviously, there's no time to do all of them. So this just shows the overall coverage of the DTP. So if you look at the black bars first, those dark grey bars, that's the standard reporting. So that's DTP 3 at 12 months of age. You've got non-Aboriginal children on the left, Aboriginal children on the right. And I've just split up the year groups as well, because we do know that coverage has improved over time. And what those black bars show is that coverage assessed at 12 months is quite high, and it matches sort of the national reporting of over 90% for non-Aboriginal children, and now creeping up to about the mid 80% for Aboriginal children. However, now if you look at the green bar, the orange bar and the purple bar, that's the on-time coverage for each of these doses. And you can see that the on-time coverage is actually quite lower, and it decreases with increasing dose. Even so when you look at Aboriginal children, there's only 65% of Aboriginal children that are receiving their 6-month dose of DTP on time. So we looked at this across those 13 different perinatal risk factors, and I'm just going to show you some of the major ones here that had quite striking results. So this is number of previous pregnancies, non-Aboriginal on the left and Aboriginal on the right, with number of pregnancies down the bottom there. And you can see that really for non-Aboriginal children and Aboriginal children, if you're 3rd or 4th born in the family, your on-time coverage is 20% or so lower than what it is if you're the firstborn in your family. So this was quite striking, especially looking at Aboriginal children. On-time coverage of that 6-month dose of DTP was less than 50%. Same sort of slide here, but now looking at socio-economic status. So this was using our socio-economic indexes for area in Australia, and in particular the index of relative socio-economic disadvantage. What this shows, with the 91 to 100% being the least disadvantaged and 0 to 10% being the most disadvantaged, is that coverage, on-time coverage is lower if you are more disadvantaged. And particularly for the 4th month dose and the 6-month dose. So again, here looking at Aboriginal children in the in the most disadvantaged area, their coverage for their 6-month dose is less than 60%. So I'd refer you to that paper if you're interested in finding out some more results. We also did look at these results for PCV coverage as well, and the findings and the patterns were very similar. So basically, despite our reported coverage in Australia of being over 90%, there are some population subgroups that only have on-time coverage of 50 to 60%, which is quite concerning. And the on-time coverage did decline with each consecutive dose. So all of those factors that I showed in that purple box, if you remember to that slide, were associated with on-time coverage. It was only, I think, gender and season of birth that didn't seem to have too much of a difference. But those groups listed in red on the slide there are the groups that have significantly delayed that vaccination. So it's also important to note that this delayed vaccination didn't improve over time. So we are seeing these disparities continue through the years of the study. So this was just to look at the absolute coverage levels. And analysis work that we're doing now, led by Heather, is to looking at the relative impact on the degree of delay for these different factors. But it is quite... I think it's quite a worrying factor. And I think for countries that do have established immunisation registers and systems, really looking at on-time coverage should be the next goal, as opposed to looking at DTP3, for example. So now I'll hand you back to Heather, who can talk about some of the other results that we've done.
Great. Thank you, Hannah. So this slide is a little similar to the one that Hannah showed before. Our other, obviously, looking at coverage in different risk groups was a key aim, and one of our other key aims was to look at disease rates and use those disease rates to look at vaccine effectiveness, not only for the whole population, but again in particular risk groups. So we can use our longitudinal data to work out rates of disease by vaccination status, and using that formula there that's at the bottom of the screen, compare the relative rate of disease in vaccinated and unvaccinated children to get an estimate of the vaccine effectiveness. So this slide shows you the how we've been able to look at rates of disease in different risk groups. And so Hannah showed you earlier the coverage by gestational age group, and this slide shows you the disease rates by gestational age group, and also the period of vaccination. So if we just focus on the dark blue bars or purple bars, you can see that the rate of disease in children born preterm, less than 28 weeks, is more than 5 times the rate in children born term up here during the pre-universal period, when the coverage was virtually non-existent for children who weren't born preterm, and was still very poor for children who were born preterm. But then when we introduced the vaccine to all children, you can see that the disease rate in the stripy bars went down in all children, and particularly that the relative rate reduction was much greater in those children who were most at risk. And this is really the first time we've been able to firstly show the relative risk of disease by gestational age group, and show that, yes, children who are born preterm are at a higher risk, but now in the universal period, the rates of disease are very similar across the gestational age groups. So not only were we able to show rates of disease by risk group, but we're also able to show rates of invasive pneumococcal disease by vaccination status. And this hasn't ever been done before at a national level. It's been done in Spain at a province level. But we were able to show that in the pre-universal period, the first set of bars here, that children who were vaccinated, when vaccination coverage was obviously very low, around 3%, that the vaccine reduced your rate of disease about 5-fold. But then after we introduced a universal vaccination program in 2005, and coverage rapidly went up to being over 90%, that the children who were unvaccinated were protected to the same extent as children who were vaccinated. That is, herd immunity was considerable and virtually explained all of the disease rates in both vaccinated and unvaccinated children. So what we can do by having rates of disease by vaccination status is then go on and calculate vaccine effectiveness. And this slide shows the vaccine effectiveness against the pneumococcal conjugate vaccine, where 7 serotypes were included in the vaccine. We've now, as Hannah mentioned, moved to PCV13, but most of our analysis was done when we were still using the PCV7 vaccine. And we were able to look at it for the first time in Aboriginal children and non-Aboriginal children separately, and by numbers of doses received. And you can see that for 2 or 3 or more doses, that the effectiveness was extremely high, above 90% in both non-Aboriginal and Aboriginal children, which was great. But what we did find that for non-Aboriginal children, 1 dose was very protective, but in Aboriginal children, that 1 dose was not providing any protection, although the confidence intervals are very wide. So just to summarise, what we've found was that, as Hannah showed you, there was poor uptake of the targeted pneumococcal conjugate vaccine. But in the slide that I showed, we can see that now the rate of disease in extremely preterm children is similar to term children. And so the question arises, the policy question, as to whether we need those extra doses now that herd immunity is so strong. We're also able to show robust evidence of the effectiveness of the pneumococcal conjugate vaccine and provide estimates of both the direct and indirect protection, and for the first time provide estimates in Aboriginal children of the effectiveness of the vaccine. So now I'll go on and talk a little bit about what some proposed future linkages might look like. And as I mentioned before, there are some limitations with our cohort that we have assembled. It's currently a static cohort based on birth registrations, children who've got both a birth registration and a perinatal record. And so there's a little bit of a selection bias. We can't look at migrants or account for migration. And so we really need a more vital registration system. And so moving forward, we would like to potentially link to the Medicare database, which is Australia's universal health care program, and link based on a Medicare, underlying Medicare unique identifier as our cohort. And of course, involve more states and territories in the analysis, as well as Western Australia and New South Wales. Of course, the immunisation register that we linked up only had vaccinations given up to the age of 7 years, and now we have a whole-of-life Australian Immunisation Register, or AIR. So in the future, we'll be able to look at evaluating adult vaccination programs. There's a separate, at the moment, separate HPV vaccination register, which is going to be integrated into AIR next year, and along with school-based registers. So we'll be able to look at evaluating vaccine programs across the entire lifespan. Would also be possible to, in the future, link up the disease histories and vaccination histories for family members to look at who acquires infection from whom, and also look at perhaps integrating individual socio-economic and education data, and this will really provide a more holistic approach to evaluating the impact of vaccination programs. And WA are pioneers in Australia in that they have been able to already link pathology data and look at the disease burden in non-notifiable diseases. Hannah, do you want to say a little bit about that?
Sure. So because it does help in WA. We've got one sort of central public pathology laboratory, which is Path West. So we've been able to do some linkage with our routine laboratory data. And the real beauty of this is that you can look at these non-notifiable pathogens, especially pathogens such as respiratory syncytial virus, RSV, which is a real global priority at the moment for prevention through that vaccination. It's likely that a maternal vaccination is going to be the likely candidate for that. So we can look at disease burden, we can look at testing rates, which is the other really important aspect of these data, because when you look at notifiable data, all you look at is the positives, and you have no idea of how many children are actually being tested. And for something like influenza, which is fluctuating and changes in testing practices due to pandemics and things, looking at testing rates is really important. So with our routine laboratory data, we don't just get positives, we also get the test negatives as well. And so what we can do from these data, and especially when it's linked with vaccination data, is that we can also do these test negative designs, which has been around quite a lot now for looking at influenza vaccine effectiveness. But this allows us to embed these test negative case control designs embedded into a large retrospective cohort established through this program, because we have routine laboratory data for the West Australian side of the cohort at least, and as well as the immunisation data. So it does provide us some advantages and some extra value that we can do with the West Australian data. But it's sort of hoped that other states can see the benefit of linking routine pathology data. And I think New South Wales is trying to come on board with this, aren't they, Heather? And they're trying to get some of their routine pathology data linked, as well as other jurisdictions around the country as well.
Yeah, no, it certainly would be a valuable addition, I think, to comprehensively evaluate immunisation programs. So just to conclude, Australia now does have a comprehensive population-based system for evaluating childhood immunisation programs. Our proof of concept has been a success, we think, and we've developed data access processes. We've been able to link large and representative cohort using probabilistic linkage methods and already get policy relevant outputs. So we hope that we've been able to provide encouragement for other countries that have national immunisation registers and also don't have unique person identifiers such as Australia. So really, apart from the Nordic countries, which have a fantastic system, and New Zealand that have got these unique IDs, most countries really don't have that system set up. So I hope we've been able to provide encouragement for those countries that don't have unique identifiers that it is possible to use probabilistic linkage and come up with quality data for evaluating immunisation programs, and that would provide robust country-specific evaluations. And if other countries are able to do this, then we can also look at international comparisons to optimise schedules around the world. So thank you for listening to us.
I think we just have some acknowledgements there. So there's lots of people that have been involved with this project and various different funding bodies and various different reference groups that have really been important. So it's just to leave those acknowledgements there. And I think we will finish there and take any questions, I guess. So Anne, back to you.
Thank you very much, Heather and Hannah, for an excellent presentation. It really speaks volumes to the dedication that the two of you have put over such a long period of time to make this research so successful and comprehensive. So thank you for all the work that you've done. We have an opportunity now for anybody who would like to use the chat function to send in questions or comments. That the floor is open to you. While we're waiting maybe for people to respond, just a question that for me that comes to mind is, given all that you have done to make this research possible, what would be your recommendations for others and maybe in different countries who want to pursue something similar? What would be the caveats maybe and just basic recommendations for launching such a study?
I think, one of the reasons that did take us so long to do this was that it was a really the first, one of the first times that we have been able to link Commonwealth data with state data. So I'm sure Australia is quite unique in that setting. I mean, Canada is also quite similar in that sort of state federated arrangement. So I think that did take a little time. But what really helped with that was just a lot of communication between the states and between the Commonwealth. And we realised at some point at the beginning that we all use different terms that really mean the same thing. So I think just having that conversation with different linkage units and different jurisdictions and making sure that when you're talking about things, you're actually talking about the same thing. So I think that's sort of one sort of take-home message, I guess, that I would have is just communication is really key with this and making sure that everybody is on the same page of when you're really talking about these different issues of linking data, what does it mean, the access, the privacy, the control, those sorts of issues. Heather, have you got anything to add to that?
I think that's a really important piece of advice, that it does require trust and communication at multiple levels, and to really get all the firstly identifying the key stakeholders is really important, and that did take us a while to identify, well, who should we be talking to, who's going to make this happen. And in a lot of cases at the start we didn't even there wasn't someone to make it happen because it hadn't been done before. So I think it's really important, as Hannah mentioned, to find the right people to talk to and be open and build relationships and come together to develop a process that everybody's happy with.
Okay, well, thank you very much. As I said, it's been a huge task, and I think that that many people will benefit from your work for sure, and I can see the opportunities for more in the future, as you've already suggested. I don't see any questions through our chat function, so I guess we'll close it for now. Just a reminder to people that you do have our emails if you'd like to follow up with further questions, and the recording of this session will be provided as well in the near future. So thanks again very much, Heather and Hannah, for your presentation.
That's okay, Anne. Thanks very much for the opportunity.
Yes, thank you, Anne.
Okay, bye for now.
Bye-bye.
Okay, bye.
Bye.